everyone, respected faculty members, distinguished guests, internship coordinators, dear interns, and fellow students. It is my privilege and pleasure to welcome you all to today's case presentation session organized by the DIO. Learning from real clinical cases is one of the most effective ways to strengthen our clinical reasoning, diagnostic skills, and patient management abilities. Today's session is yet another opportunity for us to learn, discuss, and grow as future eye care professionals. First and foremost, I would like to extend a very warm welcome to our esteemed dignitaries. Ms. Jemima Hubert Ma'am, Internship Program Head, Ms. Ompriya Ma'am, Internship Academic Coordinator. Thank you, ma'am, for your constant support, mentorship, and commitment towards shaping the professional journey of our interns. It is now my honor to introduce today's presenter, Mr. Rishwanth T. Mr. Rishwanth is an assistant professor and clinical optometrist at Sri Manakula Vinayagar Medical College and Hospital, Puducherry. He holds a Master of Optometry degree and has extensive experience in clinical practice, teaching, research, and academic administration. He actively contributes to student mentoring, curriculum development, quality assurance initiatives, and community high health programs. We are delighted to have him with us today to share his clinical expertise and insights through an interesting case presentation. Without taking much of your valuable time, I welcome Ms. Selina, Fellowship in Cornea, today's presenter. Over to you.
Thank you. I'm Selina. Today my presentation is about CAIRS in keratoconus, evaluation of corneal curvature, pachymetry and visual outcomes. So introduction, I wanted you all to know about keratoconus. Keratoconus is a commonly encountered non-inflammatory corneal ectasia. In this condition, there will be corneal steepening and thinning, which results in visual impairment due to irregular astigmatism. There are various treatment options available based on the stages of the disease. So for early stages, treatments will be given in spectacles and RGP contact lenses. When there is progression, we can go for further treatments like corneal collagen cross-linking, Intex and CAS. And in this presentation, we are specifically going to see about CAS. CAS is a surgical procedure. CAS stands for corneal allogenic ring segment. It is the insertion of donor tissue into the corneal stroma of the recipient to reshape the cornea, which restores the vision by flattening the steepened area. CAS offers a biocompatible alternative that integrates more naturally with the host tissue. So now moving on to the case report. The patient is 20 years old female with chief complaints in right eye, with vision progressive diminution of vision in right eye for the past 1 year, and there is also frequent changes in spectacle prescription. The patient's ocular history, in ocular history, there is a frequent change in spectacle prescription. Other than that, there is no other issues. She doesn't have any ocular trauma, any history of ocular trauma, ocular surgery. And systemic history is also normal. There is no history of systemic diseases and no history of allergy. In clinical findings, the patient's visual acuity in right eye is 4/60, which improves the pinhole to 6/60, and in left eye, it is 6/24, which improves the pinhole to 6/18. And the IOP in both eyes are within normal limits. Right eye, it is 15 mmHg, and left eye, it is 18 mmHg. In refraction, the patient's right eye vision improved to 660 with 7 sphere and -4 cylinder at 180 degree, and in left eye, -0.50 sphere with -3 cylinder at 140 degree. Slit lamp examination in right eye shows typical Keratoconus signs. The cornea and conjunctiva seems normal. Anterior chamber is a normal depth. Iris, fundus, and lens are normal. But cornea, we can see the conical protrusion and wax striae and fleshy skin, which are the typical signs of keratoconus. So, as preoperative investigations, the patient has undergone pentacam and ASOCT. This is the pentacam report of the patient, which shows deepening. And the Kmax value of the patient is 73.8 diopter, which is far more than the normal value, indicating that the patient has severe ectasia, which is also means the patient has keratoconus. And the thinnest pachymetry of the patient is 403. So this is the ASOCT showing the cross section of the patient's cornea, where we can see the protrusion and the thinning is starting from the posterior surface of the cornea. So this patient is diagnosed with progressive keratoconus, which is an advanced stage, and irregular myopic astigmatism in the right eye. Treatment plan for this patient, they have advised CAIRS since the patient is an advanced stage. Post follow-up procedure. The patient had undergone CAIRS and post-operatively the patient was followed at first, third, and 6 months. At each visit, the visual acuity, reflection, and both topography and tomography has been assessed. Post-op investigation. For post-op investigations, also the patient underwent pentacam, ASOCT, and other visual assessments. Pentacam for corneal topography and tomography, and ASOCT to analyze the CAS positioning. So this is the post-op pentacam report of the patient comparing the pre-op pentacam and post-op pentacam. Here we can see there is reduction in the Kmax value up to minus 14.5 diopter. Also, there is a mild fluctuations can be seen in the patient's pachymetry, but in the shape of the cornea, the patient's cornea has become more flatter compared to the pre-op. And this is the ASOCT of the patient, where we can see the CAS implantation. The CAS segments can be seen inside the patient's stroma. And this is the slit lamp photograph of the patient. We can also visualize the CAS segment in this picture, both at the superior and inferior area. Follow-up outcome comparison. In the patient's uncorrected visual acuity has improved from 4/60 to 6/12 in the 60-month review. And best corrected visual acuity has improved from 6/60 to 6/9. Patient's refractive values in sphere -7 diopter has reduced to +1 diopter, and cylinder -4 diopter power has been reduced to -3 diopter at the 6th month. Patient's K1 value is 62.5 diopter pre-operatively, which is reduced to 45.3 diopter at the 6th month, and K2 value is 67.8 diopter, reduced to 50.2 diopter, and the Kmax value has came down from 73.8 diopter to 60.4 diopter. And pachymetry, we can see mild fluctuations. Pre-operatively, the patient's pachy value is 403, and which has become a stable value of 6 months to 361. So coming to discussion, we all know keratoconus is a progressive disorder which results from the stromal weakening. So the visual acuity is also reduced due to the irregular astigmatism caused due to the corneal steepening. And CAS acts as a biomechanical modulator within the corneal stroma. thereby distributes corneal tensile forces, leading to corneal flattening and regularization. So, by flattening the steepened cornea, the visual acuity can be improved. And there is an improvement of visual acuity following CAIRS implantation. There is also significant reduction in corneal curvature. Especially, we can see that the Kmax value has decreased from 73.8 diopter to 60.4 diopters. And there is pachymetry fluctuations, which can be due to the reshaping of cornea is still in process. CATS represents a promising tissue-based approach for corneal reshaping in keratoconus. So to conclude, CATS resulted in visual acuity improvement, and there is also a significant improvement in K values, which is almost a 14 diopter improvement. And the pachymetry fluctuations are due to the corneal reshaping that is in still process. So to say overall, CAS appears to be an effective tissue-based option for keratoconus management. Thank you.
Yes, Selina, thank you for presenting.
Thank you.
Over to Rishwanth, sir.
Yeah, ma'am. Selina, your presentation was so good, but I have little corrections or feedbacks in it. Okay, can you show me the slides?
Yes,
Selina, I think your background, there's some noise. If you can move away from that, it'll be nice.
Sure.
That is the slide. Third one. Third slide. Yeah, in ST. Yeah, next one. In ST, you mentioned only about the right eye. Yeah. While presenting the case, you have to show what is the full ST in it. Okay. There is no mentioning of the left eye. Okay.
Okay.
I want to mention about that. So next slide. Okay. That is one major thing is missing for keratoconus because keratoconus is an what kind of disease condition? Hello.
Yes, sir.
Keratoconus is an what kind of condition?
It's a ectasia type of condition.
Okay, super. And it is a 10%. It's a genetic condition. Okay.
Okay.
The family stays missing in it. Or not mentioned about the family stay.
Okay.
Okay. In refraction part, what is the major sign we can see in the for keratoconus patient through refractions?
In retinoscopy, we can see scissoring reflex.
Yeah. So this is the major sign. Before going to the slit lamp, it will because the mild or early stage we can detect through slit lamp. Retinoscope only. Okay.
Okay.
You want to mention that refraction value also.
Okay.
Okay.
Yes, sir.
These are the feedbacks I want to tell you. Okay. So do you think that comparison table? Come to the comparison table. In that, the Kmax value. Why did the corneal thickness reduces after surgery? Because the corneal thickness has been reducing from 403 to 361.
Yes, sir.
Why it's reducing?
So the cornea is still undergoing reshaping. So there
Yeah.
may be
So,
fluctuations in packing.
yeah, that is not reshaping, that is remolding effect. Okay. Remolding effect and tissue hydration changes has been happening there. That's why the thickness has been reducing to 403 to 361. It's
Okay.
an healing process. Okay, good.
Okay.
Okay, and then Kmax value. A patient with high Kmax value may still see the may still see reasonable because our visual acuity with pinhole is 6/16. No.
Yes, sir.
Yeah, BCVA 6/60. Very off.
Yes, sir.
Would they can see? I'm asking, the Kmax value is so high. Okay. Would they able to see that reasonable amount?
No, sir. There will be ghosting and glare.
Yeah. I'm not asking the clear image. I'm asking any reasonable image. The 6/16 means any shades, any object they can not clearly. The reasonable visual acuity they can see.
Sorry, sir, I cannot understand.
Okay.
Actually, the patient's correction is around 7 diopter sphere and nearly a K value of 62. So what sir is asking is, uncorrected, will the patient be able to have that vision, and best corrected, will they be able to have 660? Am I right, Rishwanth?
Yeah, ma'am. Yeah.
Best corrected, the speed is plus 1.0 diopter. After surgery.
After surgery, yeah.
After surgery. Okay. But in case
So
of
before
high
surgery, sir
Kmax,
was asking.
yeah. Because in the high Kmax is there, no. The patient
Yes,
still able to see any reasonable amount of visual acuity because the cone is decentered. Decentration of the cone is very important for keratoconus patients, okay? Because the visual acuity may be good if the cone has been decentered. That's why I'm asking. Okay.
Okay.
If you think the CAS is effective or intact is effective, which one is effective?
CAIRS is effective, sir.
Why?
In CAIRS, we are taking the segment from a donor tissue, which can be more biocompatible to the host. But intact, it is a synthetic material.
Okay.
So there is more side effects in intact compared to CAIRS.
Okay. Side effects also is there. Because in early stage, the infection or inflammation or epithelial defects may occur. And later stage, the neovascularization also may be developed. Okay. But comparing to intact, CAS is good because less resection value. Since it is a biological tissue, there is a better biocompatibility is there and less resection value also there. Okay.
Okay, sir.
And then it has been integrated with the stroma and other structures better compared to synthetic material.
Okay.
There are many treatment options also there. Spectacle, contact lens, there are surgical options also there. Why can't we go for this patient as scleral contact lens? Do you think that is better for them?
The patient's cornea has become more cheaper. We can see that in keratoconus, in the pentagram report. So maybe scleral lens won't be a good option since This patient is in advanced stage. Also, the Kmax value is very high.
Super. Yeah, scleral lens also is one of an excellent alternative treatment, but that they do not reshape the cornea. And they do not halt the progression of keratoconus. That's why you're going for surgeries. Okay, good. Okay, ma'am. I'm satisfied with the answers.
Thank you.
Thank you so much, Rishwanth, for joining us and moderating this session. So,
Thank you.
Yeah. So, students, if you have any other doubts, you can ask. You can either post in the chat box, you can unmute and ask any doubts you have. Actually, I had another meeting, so I joined a little late. So, not sure if this was covered. Who found this procedure of CAIRS? Was it discussed?
Yeah.
Okay.
No, ma'am.
No, okay. So
Susan,
I open this
okay.
to others, except Selina. Can anyone say who introduced this procedure?
Dr. Susan.
Susan.
Okay. Okay. Full name? Very good. Where is Dr. Susan from? Where is she working?
Dr. Agarwal.
Dr. Agarwal, yes. So we should all take pride that Dr. Susan Jacob from our own Dr. Agarwal has introduced this procedure of CAIRS. So everyone, you better know about this procedure well. So yeah. Any other doubts you have? Okay, if no one has any doubts, we can wind up this session.
1 minute, ma'am.
Yes.
Keratoconus gradings.
Okay.
Also not mentioned in the WBT.
Okay, yeah.
Grade has been mentioned, grade 4, but there are 2 types of gradings there.
Yeah.
For keratoconus, there are 2 types of grading method.
So
Which
can
grading
anyone
method
tell the
works,
grading of
Selina?
keratoconus, or we can leave Rishwanth to explain it to the students? Grading of keratoconus, can anyone say? Fellowship students, how many fellowship students have joined? Any grading, you can post in the chat box. So I do not want this session to be just a one-sided conversation. Would be very nice and interactive if all of you, give your points and anything. Whether you're right or wrong, you can just put it in the chat box. So right from the basics till the advanced procedure, we should all be familiar with. So I'm glad that you covered about the case history, about the scissoring reflex and retinoscope. That was all very nice. So apart from that, yes, 4 grades. Yes, Rajan. Very good. Padma Shri, mild, moderate, advanced, severe. Okay. Good job, Padmashri and Rajan. So I'm not sure this online presentation is quite challenging. Yes, Rishwanth, you can go ahead and explain.
There are 2 classification, 2 types of classification. One is Amster-Kumba classification, and then Bellin ABC system is there. There are 2 types of system to classify this. And then in Amster system is an ideal one to use. And there are 4 stages. Rajan has mentioned 4 stages. No, in that we have to see for refractive error, keratometry values, and corneal thickness. Based on the values, we may grade this is on grade 1, this is grade 2. But we have to see for this refractive error, what kind of refractive error.
Is there anything else you want to tell, Rishwanth, or we'll wind up the session?
No, I'll share the notes through
Okay,
the
all right,
WhatsApp
fine.
groups.
Yeah. So we will post the notes and also not only this CAS procedure and advanced treatment options, right from the beginning, all the early signs of keratoconus you should be able to pick up as interns in the clinic. So even if no one has told that they have keratoconus, right from the case history, sometimes they will say there is frequent power change. They frequently have blurred vision. In spite of changing spectacles, their vision is not clear. All these are early signs, so that you should know. And is spectacles enough for keratoconus or why it's not enough? So those points you should know. So right from the beginning till the advanced procedures, as interns you should know, and you should also know the signs, symptoms of keratoconus. What are the signs of keratoconus? Can anyone post it in the group or you can unmute and tell? Signs of keratoconus, what all do you see? Quickly. So quick, you can all post in the chat box, unmute and tell. I'm asking a very simple question, signs of keratoconus. Selina, you can also post in the chat box or unmute and tell. Sophie, are you there? Okay, very good, Arnagiri. Thank you. So yes, Munson sign, scissors reflex. Yes, right from rubbing of the eye. Yes, warped striae, apical scarring, fleecious ring. Very good, wonderful. Okay. And what is the type of astigmatism you see in keratoconus? Yes, Divya Dashni, good job. What is the kind of astigmatism you see in keratoconus? These are all quick. We'll have a quick run through of this. Not oblique. What is the type of astigmatism? Thank you, Sharmila, for answering. What is the type of astigmatism we see in keratoconus? Okay, very good. Divyadashni and Selina. Yes, irregular astigmatism. So since they have irregular astigmatism, glasses is not going to correct it. So initially you can give RGB lenses. Later on you can go for rose-K lenses or scleral lenses, and in advanced cases you go for surgeries, and different types of surgeries and procedures are there, and one such is the CAIRS. All right. Okay then. Fine then. So we'll wind up the session. So thank you so much, Rishwanth, for joining us and sharing your insights with our students.
Thank you, and thank you so much.
Okay.
Thank you so much for approaching me to do this session. It's my honor.
Thank you. Thanks to Om Priya for coordinating this and getting this done. Yeah. And thank you, Selina, for your presentation. So
thank you, ma'am.
Yeah, so you can improve your volume a little bit, Selina. So next time.
Sure, ma'am.
Yeah, okay then. So thank you everyone for joining the session. A big round of applause for everyone who joined the session, and especially for Selina and Rishwanth. So see you next month. So every month we have this case presentation. If you have any interesting cases, please share with us. We can have a discussion on that. Thank you. Thank you once again. Bye-bye.